Good morning, everyone. I think since I understand we have a very full and busy session, I am going to get us started first thing. So I'm Jen Brash. I'm at St. Joe's in Hamilton, and I'd like to welcome everyone this morning to our session on new guidelines for methadone prescribing with Andrew McLeod and Jennifer Wyman. This is session 5A. Before I introduce our speakers, I am first of all the moderator, and I would have a few reminders to begin with. This session is being recorded. If you have a question during the session, please enter it in the Q&A box. We can certainly use the chat function during the session, but it would be helpful for me organizing the questions if you could use the Q&A box. You can add comments and so forth in the chat. Once the presentation is over, you can also raise your hand, although I understand we're not going to have too much time for questions. Please let me introduce the speakers for today's session. Dr. Jennifer Wyman is currently an assistant professor in the Department of Family and Community Medicine at U of T. She is medical director of the Substance Use Service at Women's College Hospital in Toronto and clinical program lead with PHI. Her work centers the experience of people with lived and living experience of substance use in education, research, and guideline development. She has led the development of several guidelines on opioid agonist therapy, as well as tools to support implementation of addiction care in emergency department and primary care settings. She's involved in evaluating the impact of changes in care on the outcomes and experience of people with opioid use disorder. I'm also very pleased to introduce Andrew McLeod, a registered social service worker and an addiction counselor, as well as a person with lived experience who accessed methadone for nearly 2 decades. Andrew works as a community consultant for PHI and as a social service worker and addictions counselor for Alpha House and Renaissance. Welcome, Jennifer and Andrew. Take it away.
Thank you so much. It is our pleasure and responsibility to be presenting PHI's new methadone guidance. The obligatory acknowledgements that this program has received in-kind support, like a lot of in-kind support from PHI as logistical support. I received salary support from PHI for my work in developing this guideline and other clinical programs. And Andrew, I think you need to say yours as well.
Absolutely. Thanks so much, Dr. Wyman. I receive an honorarium from PHI for the work that we do with this program. Thanks so much.
And I also received some research support from Women's College, from CIHR, some speakers honoraria from the OCFP. I'm an employee of Women's and of PHI.
I don't receive a salary from anybody, so this isn't applicable to me. Thank you.
And in terms of potential bias, so Andrew and I, along with this amazing group, are all co-authors of the methadone guidance that we're going to present today. And in terms of mitigating bias, we want to say that we've really done an extensive review of the peer-reviewed literature, and we intend to have this document peer-reviewed as well in its final form. And I know Sarah would not consider herself an author, but her contributions as an editor and knowledge broker are also invaluable. So I hope some of our co-creators are here in the session and able to answer or respond to some of the comments, because we hope as we go through that there will be questions. We've got a couple of cases at the end, and very curious about people's thoughts around some of what we're suggesting. It'll be a bit challenging for me to keep an eye on that chat, so hoping that Jen Brash, Lisa Bromley, and others will be able to help us with that. Andrew.
Thanks very much, Dr. Wyman. So the background behind this, in 2020, fentanyl and fentanyl analogs accounted for the majority of overdoses, and we say 99%. So the CPSO guidelines, they were rescinded back in 2021. And this new framework, this new document, it looks to address both the massive amount of deaths, as well as due to the drug supply, the really high opioid tolerance, as well as this being such a life-saving program, OAT and methadone, that we're trying to address the low retention and low engagement in methadone. Thanks.
Sorry.
Perfect. Thanks very much, Jennifer. So just in terms of methodology behind this, our group, as we were just talking about, was made up of 5 physicians, 2 people with living or lived experience with methadone. We had 1 nurse practitioner and 1 pharmacist. And this group met regularly. It was a long process in terms of us putting this together, and the wide range of people that we had really added to the benefit of having so many people with different walks of life participating. Thanks.
So we really acknowledge that there are different kinds of experience. There's the literature, there's our clinical experience, and the experience of people who actually have lived with being on OAT. This is a consensus-based guidance document. Its focus is on practical implementation of clinical care. It's intended to encompass a lot of aspects of OAT care. And I have a feeling that people are waiting to hear, well, what's the highest starting dose that you're going to say we can go with? And that, of course, is a part of our presentation, a part of the document. But I just wanted to give an overview of so many of the other elements that will be included in the guidance document and that are really critical. Jen Brash, if she hasn't, is going to put a link to the draft in the chat. I want to emphasize that this is a provisional draft. It's not posted and shared widely at this point, but we wanted people participating in this session to have the opportunity to delve a little deeper than what we have time to describe today. And we look forward to having that review document available in the next couple of months. Andrew.
Thanks so much, Dr. Wyman. So we're going to have some questions that are going to be posted. Right now, Jennifer is going to post the first poll question. And the question is this: what's the highest starting dose of methadone that you've prescribed? So we're going to give it about 15 or 20 seconds to give the people that are in this group, all the attendees, an opportunity to answer. So again, what's the highest starting dose of methadone that you've prescribed?
I see that hosts and panelists cannot vote.
So there's, for those who are in the attendance, you should be able to do it. We're going to close that question and we're going to move forward. The results just posted up. We're looking at them now. So 6% of people, 20 milligrams. We've got probably the second largest amount, which is 33% at 30. Small amount at 35, and 46% of people starting dose of 40 milligrams. Thanks very much.
Yeah. Okay. So next question.
Yeah. Our next question. I'm just going to move forward here. So what's the highest dose you've used for a methadone restart? So restarting somebody. And Jen has launched that question. We're going to give it about 15 or 20 seconds for people to respond. 30, 40, 50, 60, or other.
We had a good 60 people last time. Whoop, there we
go.
Yeah.
Yeah, which is fantastic.
Mm-hmm.
I love when these work.
And thanks to Nathan. Nathan just commented in the chat. He says, it depends on how many doses have been missed, which is a very good point. Yeah. So results for our second question, 30 milligram, 20% of the people, 39% at 40 milligrams. And then we've got an even split between 50 and 60 milligrams with 15% each. Okay, excellent. Yeah. Thank you.
So interesting to me, thinking about, just seeing some people, well, I'll let you post question number 3. Do you co-prescribe methadone with SROM? Just thinking about, seeing that some people are still practicing more conservatively. Others are being a little bit more, I don't want to say aggressive, a little bit more flexible. Despite or in spite of a lack of formal guidance, and the lack of formal guidance and, sort of regular anticipated CPSO checks, I think has certainly created so much more room for flexibility and clinical judgment. And also, a lack of clarity around what is sort of a community or accepted standard. Wow, okay, that's really interesting. So 81% are co-prescribing methadone with Strom. I guess this is a Medify crowd, so that means people know about our guidance from a few years ago. So maybe a bit of bias here. But just to say that, co-prescribing methadone and Strom is not something that is done routinely across the country. It's certainly not done in the US, where Strom is really not allowed under the federal OTP programs. There's a presentation going on right now, unfortunately, about people's experiences with Strom. It's the beginning of a qualitative study, and I encourage you to tune into the video of that when you can. We're really curious about what more information we're going to learn from people about the benefits of co-prescribing as opposed to higher doses of methadone. So thank you for that engagement. So we spent quite a bit of time trying to understand where the original 30 milligram maximum dose of methadone came from, and really went back. I think the reality is that that dose was based on observational studies that identified the first week of methadone therapy as a period of high risk for toxicity in people starting methadone at doses higher than 30 milligrams. And that's where that dose came from. And of course, for many years, most of us practiced under 30 because you never wanted to be the person who was prescribing the highest dose. So it was a big deal in 2024 when SAMHSA announced that the first day dose could be up to 50 milligrams, but not higher. And of course, that was intended to be a decision made in consideration of the type of opioid use, the medical history, the severity of withdrawal, et cetera. But that really started to open up all kinds of new options, although there were people who were already sort of trialing more rapid initiation protocols. And so we spent quite a bit of time looking over the past year at the published and the unpublished literature around higher dose protocols. And again, these are not, sort of state or provincial or national guidance around specific, well, I shouldn't say that. The BCCSU is what it is, but in terms of the American studies, which I'll review, I'm sure everyone is aware of the BC guidelines, which identified an initial maximum dose of 30 to 40 milligrams with titration every 3 days, but also a comment that higher doses may be considered on a case-by-case basis for those with a documented history of fentanyl use and experience of methadone. So we were really informed by that and thinking about what we wanted to bring along with this review. We looked, as I said, at the literature, and I'm just going to briefly review some of what we found. There's an article by Stone set in Rhode Island that was a retrospective chart review of 154 patients with starting doses of 30 milligrams, increases of 10 milligrams day 2 and day 3, and then holding for a week. Of note, those patients had a daily nursing assessment to look at withdrawal and sedation. There were no issues other than in the 2 people who actually withdrew from methadone treatment. Those were the 2 fatalities, otherwise no fatal overdoses. The Faster Paths program was a trial in Boston. They were trying to get around the 72-hour rule in the States, which I don't fully understand, but they created a bridging clinic that would allow people to get into an OTP program and get their doses titrated rapidly, then with referral onto treatment. And their initial starting doses were based on a range, so clinicians could prescribe from 10 to 50 milligrams. They found that at the beginning of the program, the median doses were just about 30 milligrams on day 2 and 3, 40 and 50. So as they reviewed their charts, there were 150 people, 142 unique patients because some people restarted. They actually found that over the course of the program, initial doses increased because clinicians became more comfortable as they observed that people were still experiencing tolerant withdrawal on day 2 and 3 and any kind of lack of sedation. So their revised protocol was starting at day 40 and then moving up to 50 and 60. So with daily increases and then referral on. The Steiger protocol, I'm going to talk about a little bit more on the next slide. And then there was an unpublished study presented at ASAM in 2024. We found this was a review of a group of clinics across 3 states. Again, people with high intensity opioid use, a review of 100 patients. And they moved towards starting doses of 30 with a second dose of 10 milligrams on day 1, an increase to 60 milligrams day 2, then 80, and then waiting for 3 days while allowing people to adjust to their doses. Again, because of our time today, we're not doing a review of methadone pharmacology, but we know that based on how methadone is metabolized, it takes at least 3 days, typically assuming normal metabolism, for that dose to reach steady state. And so it's really important to not be increasing day after day without allowing for that stabilization to occur and the opportunity to actually reassess for withdrawal and sedation. So the Steiger case series was based on a retrospective chart review of 93 patients who were offered rapid induction and completed by 65 patients. Daily fentanyl use self-report was the criterion, and they excluded those at higher risk of overdose based on all of our kind of typical criteria for what makes up high risk. Their protocol was 40 milligrams day 1, 60 day 2, 80 day 3, as you see, followed then by increases every 3 days with a maximum weekly increase of 20 milligrams. And what they found was that by day 7, the average dose was just about 90 milligrams, which is a pretty far cry from what we can achieve right now. There were no reports of sedation, fatal or non-fatal overdoses within 14 days. And they also reported their retention rates as 58% at 30 days. Now, also acknowledging, there are elements in addition to the dose, right? So they had a daily check-in with a pharmacist or a nurse around sedation. They were able to offer some additional supports as well. And the same was true in that Boston case. They talked about having, a sort of high touch points where they could help people with other things, very flexible hours. And their retention rates, I think, were over 80% at 30 days. Still, we know that there are concerns about the risks of methadone overdose. A single dose typically happens through accidental ingestion in an intolerant individual or someone who's lost tolerance. But there are deaths during the first 2 weeks of treatment, particularly when tolerance has been overestimated or other opioids or depressants were prescribed or taken with methadone, and benzodiazepines are the most common concern for that. And so we really need to remember that because of that, that delayed, the half-life resulting in delay getting to steady state, if someone experiences full suppression of their withdrawal within 24 hours, they're probably going to experience sedation and symptoms of toxicity as the tissue stores accumulate. So our approach was to take all of this information, again, the published, the gray literature, our clinical experience, the experience of our contributors with lived experience, and really look at creating a framework that considered opioid tolerance, the risks of toxicity, and also the risks of not being on OAT, which of course are very real. And so we approached tolerance as in these categories from low to very high. And again, many of us see people who have high and very high tolerance, but that's not all of the patients who come to us to start methadone. There still are people who have been using oxycodone, codeine, or some hydromorphone tablets. Those would typically be people that we consider to be low tolerance, or those could also be people who were on opioids or OAT, but have recently been off, and so their tolerance will be diminished. Moderate tolerance, so people who are using pharmaceutical tablets. This could also include people who are buying tablets. They may not think that they're using fentanyl, but we know that what's in those tablets is actually really hard to know. So they could be exposed to fentanyl potentially, but they're not sort of fentanyl users per se. High tolerance being people using fentanyl daily or near daily, but typically we sort of categorize that as being less than a gram a day, regardless of how they're using it. And very high tolerance being people using a gram or more a day of fentanyl. And we know that there are some people who are using much more than that. And then you won't be surprised by the considerations around risk for toxicity. So the classic age 65 or older, concurrent severe COPD, liver disease, conditions associated with QT prolongation, medications that are sedating or prolong the half-life. And we don't have time today to think about, all of those medications that interact with cytochromes, but we certainly encourage people to look at medications and have sites that are their reliable go-tos for that. Concurrent substance use of alcohol and benzodiazepines at levels that cause sedation. So not, a drink or, 1 milligram of lorazepam at night, but substantial doses. And then in terms of lower risk for toxicity, people who have demonstrated their tolerance to methadone by being on doses more than 90 milligrams in the last 3 months could be considered to be at lower risk for toxicity and therefore may be considered for higher starting doses. And then this last category, which I think we struggled with a little bit, because people who've had recent overdoses may be at increased risk of overdose again with prescribed methadone based on how they're using opioids, but they're also the people who might benefit the most or particularly from rapid stabilization. And so all of these are things that need to be considered when we're thinking about this balance. And so we came up with a framework. It struck me that this is sort of similar to the framework that we came up with for the CARI guidelines, where we, wanted to give structure and guidance, but also ranges. And obviously anything that I'm presenting today or that is included in this document as guidance needs to be applied in a person-centered way and with clinical judgment to look at all of the factors around the individual. But you'll see that for people with very low tolerance but high risk of toxicity, there's still a recommendation for a low dose and potentially for really considering buprenorphine. So that might be someone, for example, who has been off opioids. Perhaps they went to treatment or they tapered off, but they're concerned about their risk of a return to opioid use and they want to have something on board to protect them. For someone with that moderate tolerance, so let's say they're using pharmaceutical, oxycodone, the example, 380s a day, with some increased risk of toxicity. So maybe they're also using benzodiazepines or they also have alcohol use. We still need to be thinking about those risks when we think about their initial dose. So a range of 10 to 20 and dose increases of about 10 milligrams. Again, there's a range, but that's not someone that we need to start on 30 milligrams right away. So we're looking at both the tolerance and the toxicity for each of these individuals. As we get to someone who has high tolerance, so that's someone who's using fentanyl, let's say up to about 1 gram a day. If they have other significant risks for toxicity based on other substance use or medical conditions, we would still consider 30 milligrams to be a dose that should be considered for the starting dose, again, related to the risks of toxicity. But if we've got someone with high tolerance and no major risks of toxicity, then a dose up to 40 milligrams would be considered. And for someone very high tolerance, so that's using fentanyl 1 gram or more a day, 40 to 50 milligrams. But in that case, we would be looking at not only their fentanyl use, but also some evidence that they had tolerance to methadone doses at decent doses, so over 90 milligrams in the last 3 months. So I'm going to leave that there for just a moment. Again, the link I think Jen would have posted in the chat. And we're going to talk about some cases in a moment to think about how to apply these. But I'm wondering, as people have a chance to think about that, how is that feeling? We're going to come to that, a question about that in a minute. This is obviously a change from the guidance that we presented a few years ago where we suggested co-prescribing methadone and SROM. And the rationale at that time was that we didn't have the sense of evidence or confidence, I guess, to prescribe higher doses of methadone. And so the goal of co-prescribing methadone and SROM was similar. It was to achieve an effective dose of OAT more rapidly than using methadone alone. We certainly had heard from people that the doses of methadone that were available were not adequate. We also looked at the different metabolism of SROM and methadone because of SROM peaking later and not bioaccumulating. We felt that that was a safe option. The guidance was developed really based on a protocol used in Saskatchewan. Since then, there have been a small number of case reports, but certainly observations of our authors, both the clinicians and people with lived experience, is that people who use fentanyl have found the SROM augmentation to be really helpful. And then what about methadone and short-acting opioids? We again sort of looked at what do we know about this and acknowledged that there is a time that short-acting opioids, so that would be IR morphine or hydromorphone, could be considered, recognizing that our long-acting OAT opioid is not going to manage all of the withdrawal initially, and that short-acting opioids can have a role, again, in the context of a thorough risk-benefit assessment, appropriate documentation, and real consideration for whether those doses are being observed at a pharmacy or taken home. And that take-home doses warrant the same considerations as take-home methadone doses in terms of ability to store and manage those medications safely. So, Andrew, do you want to pose this question, and Jen, post it, please?
Thanks very much, Dr. Wyman. So for our fourth poll question, reflecting on these dose recommendations, I feel bored because I'm already doing this, or a version of this, frustrated that these new recommendations, they don't go far enough. Apprehensive, geez, this seems like a whoa. Or optimistic, this seems reasonable. We'll give everybody about 10 seconds or 15 seconds. Oh, wow, that's great. So we're looking at very few people are bored. That's wonderful, especially on this rainy day. And we've got the majority of people, 78% said that this looks like a good next step, 10% of people saying they're a little apprehensive, and 6 people saying that they don't go far enough. Thanks so much.
All right, I'm hoping we have a chance to hear from those who are already bored or frustrated, and learning a little bit more about how people are applying these. So, Andrew, over to you.
Okay, thanks very much, Dr. Wyman. So this here's a quote. I'm going to give everybody about 5 or 10 seconds just to read through it. It's a quote from a person with lived experience with methadone. So we've been talking about the way the dosages work, and this kind of brings us into our next section, where we're going to talk about what's it like for somebody who's actually living in the program, and what does it feel like. As we were saying at the beginning, I accessed methadone for a better part of 2 decades. For 18 years, I was on methadone, and had some amazing experiences and some pretty horrific ones. And when I was asked to come in and participate in this, both Ashley and myself met to review what are the things that makes treatment retention more likely, and accessibility. And ultimately, the biggest thing that came down was having a positive therapeutic relationship, one where I'm able to openly talk with my practitioner in regards to what my goals are and what I want to do, and being able to be honest with my doctor. When I first came into my very first, what I would have called a methadone clinic back then, I didn't know what I was getting into. I didn't understand it. And there was a lot of factors that made this program less than appealing. And I didn't really feel like I got all the information that I needed. Walking in and having people offering to sell you drugs, that was difficult. Hours that were incredibly restricting, and unable to go to work or travel, because all of a sudden I was on this program, and not understanding what I could ask my practitioner for, being afraid to tell my practitioner that I use drugs over the last week, and that all those things prevented my ability to to do well or to even ask questions that were honest. They limited having a positive therapeutic relationship. Can you move forward to the next slide there, Dr. Wyman? This is a quote that came out from somebody who said, OAT shouldn't be a full-time job. And I could absolutely relate to this. The most common word that I would hear when I told somebody that I had gotten onto methadone or that I was going to the clinic is somebody said, oh my goodness, you're on that liquid handcuffs. You're going to be sitting at that clinic for hours. And I thought, geez, there's no way I'm going to be sitting at the clinic for hours. And then fast forward 3 months, I would walk into a clinic and sit there for 6 hours waiting to see a doctor. I felt restricted. I wasn't able to go anywhere. And even when I wanted to try to be abstinent from using opiates, I'm sitting there, and as I'm walking in the door, there's a guy that's opening the door for me saying, hey, I've got some oxy. Do you need some? When we sat and met, one of the biggest things that we said was, this shouldn't be difficult. I mean, the majority of the reasons that I watched people drop off the program were not because they were using, but because accessing, OAT was so difficult. On top of the things like somebody selling drugs, I mean, that wasn't the biggest deal. Like, I knew a lot of people that were selling drugs, but the fact that I had to be at the clinic, there's really small window of time to be able to see my doctor. So some of the things that we talked about, having convenient hours, options for possible virtual visits, telephone visits, as well as scheduled appointments. The different ways of connecting with the clinic, possibly via text or email outside of appointments. And I'd say the biggest one is, when things come up, being able to have some flexibility with my prescriber and making some changes. Can you forward to the next slide? When somebody would come in to the clinic, and when I came in, I didn't have any supports. I met a lot of people there that were, either homeless or experiencing a huge amount of the trauma that goes along with daily opiate use and using drugs. And we talked about having this walking in the door and somebody selling drugs, but it goes a little bit beyond that. Having access to primary care. What do I do when I don't have I don't have any ID? How am I supposed to get my blood work done? Having somebody there that would that speaks my language, so to speak, and that looks like people with living or lived experience, coming in there and finding, I haven't had something to eat in a week. Is there something, and I'm in here trying to take the methadone, and there's so many ways that we can improve what person-centered care or a safe environment feels like. Last quote that we've got up here says, it's hard to get stable when you've got nothing to eat and nowhere to live. So having people that have been through this and know how to navigate the system, something as simple as having some snacks there, and ultimately me being treated like a person. I usually say that the thing that changed everything for me, I told you guys about sitting in a clinic for 6 hours waiting. And that day that I sat there for 6 hours, I was towards the end of the day. I'm like, I've got to be seen now. I mean, they're closing in another 2 hours. And I stepped outside for a cigarette, came back in, and was told, oh, they called your name. You're going to be put to the bottom of the list. I get into that appointment, and the appointment lasted 45 to 50 seconds, where the doctor said, any changes? No. Okay, great. Hands me a prescription, and off I go. So I've spent a whole day sitting there. On the polar opposite of that, I walk in to see who was my provider for most of the 18 years that I was there, and I would come in, and my doctor would say to me, Andrew, how are you doing? Anything going on? How's your daughter? How's Madison doing? What's happening with your with your family? And this doctor had taken some time and treated me like a person, and that absolutely made me more comfortable and made me more willing to sit down and be honest with my practitioner, because that's what we need. We need a collaborative relationship. Thanks.
Thank you so much.
Thank you. We're going to go into our first case study, and I'm just going to read to you guys what this is. This is somebody, we'll call him Mike, 45 years on methadone at 110 milligrams until about 3 months ago. Mike lost his partner. After missing doses, his prescription was discontinued. He's using fentanyl, a gram or more a day, smoking it and injecting it. Uses crystal meth, no alcohol, no additional benzodiazepine, no other medications, no known health conditions. A urine drug screen showed positive for fentanyl, benzodiazepine, crystal meth, and hydromorphone.
Yeah, so just to say, he hasn't been on methadone for 45 years, but he's a 45-year-old male.
Oh, I'm sorry. Did I say
methadone.
45 years?
Well,
That
some
would
of our
be
patients, that'd be a long, yeah.
That would be a long time. I'm sorry.
Well, that's a whole other topic, right? The sort of aging population of people who've been on methadone for some decades now. But, you know, this is an individual, we would say, very high tolerance. I'm really hoping that people will start putting some comments in the chat. And, you know, Jen, if there's something that you see that you want to bring to our attention, please do. Lisa B, or anyone else who's part of this group who wants to help respond to some of those things, that would be great. So, so we would consider Mike to be someone with very high opioid tolerance, so using a gram or more of fentanyl a day, and no increased risks of toxicity, known experience of methadone more than 90 milligrams for at least 5 days in the last 3 months. He's someone where we could start initial doses at 50. You know, I think from what we've heard, and probably you have heard from patients, 50 milligrams still isn't going to be enough. And lots of people have tried methadone on their own from others and would say, you know, 60 milligrams doesn't touch them. But again, you know, we're thinking about how do we provide guidance that people are going to be able to lean on if they're both less experienced and more experienced practitioners, again, using clinical judgment. So assuming that Mike, you know, gets all of his doses, the good news is he's actually at 80 milligrams on day 7, which, you know, we know it's a bit of a stretch for people to get there every day, but is doable. So let's say that Mike, after 4 weeks, is at 130 milligrams. He's actually feeling not badly at all on his dose. He's still using here and there, but a lot less, probably most days, but he hasn't had any big mishaps. He's not really using anything else. He's getting most of his doses, but Sunday is really a challenge. The pharmacy is open for 2 hours in the morning, and so he's fairly consistently missing that. Then he goes out of work. Someone offers him you know, some construction thing that he can help out, and he misses 4 doses. The pharmacy cancels his prescription. By the time he gets back to see you, a bit later than expected from his 4 days away, he's now been off methadone for 6 days. I'm hoping there are some thoughts in the chat about, you know, what you would be thinking about in terms of restarting him. Would you go back to restarting based on initial dosing criteria? So that might be 50 and then 10 to 15 every 3 days. Would you be interested in being a little bit more flexible? What other considerations would there be? So as I mentioned earlier, we had the privilege of meeting with Scott Steiger, who published that San Francisco protocol. And he shared with us what they've adopted in their clinic in terms of a missed dose protocol. Again, I just want to say, I'm not telling anyone they should do this. We're sharing what we've learned from him. We've spoken to others also about restarts. And their goal and what they've found to be effective without, again, any evidence on their follow-up of complications, their goal is to get people back to a full dose by day 2, as long as they haven't missed a full week of methadone. So the approach that they had taken was if someone missed 3 days, to reduce their dose by 10% and return to full dose the next day. 4 days returned by 20%, as long as they were tolerating that, back to full dose. 5 days reduced by 30%, then back to the full dose. And at a week or 7 days, decreased by 50% or to a floor of 60. So basically, you know, their starting dose overall.
So one thing I just wanted to pop in, I'm sorry for cutting you off, Dr. Wyman. This situation where I'm finally at a dose where I feel decent,
Mhm.
and something happens. Was one of the biggest stumbling blocks that I found. I would just get to where I was doing all right. Things were finally starting to come together, and all of a sudden I'm starting back at the beginning, and it's going to take me another 6 weeks to get to where I need to be. I
Yeah.
was almost at the point where I'd get a carry, and now I can't. And so seeing some of the way that these were handled is really beautiful. Thanks.
Yeah, I know that was really impactful for you. So again, so what was Mike's scenario? He was on 130 milligrams, tolerant to that, missed 6 days, by the guidelines and by what we've really, said here. The approach would be to start at 50 and go back to 15 every 3. But here are some other options to consider, such as restarting at 50, but increasing by 15 milligrams daily for 3 days. So similar to what we would do if someone had missed, 4 days, right? Or, we were able to kind of start them at that 50% and go up by 10 for 3 days. I think it's fair to consider in someone with such established documented tolerance, increasing a little bit, and then reassessing, potentially starting at 60 milligrams, which is still a little bit less than 50% of the dose. I'm not here to recommend one of those specifically. I think that they are actually all options with, careful thought, assessment of what he's been using, what has he been using in between in terms of maintaining tolerance, and careful documentation. And then, how could we avoid this situation from happening again, right? What about his missed Sunday doses? What if he has another opportunity to get to work? We've heard Andrew say that being on methadone should not be someone's full-time job. If our goal is to help people, stabilize in their lives overall, which includes ideally work, family, social supports, we want people to be able to work. And so I know that this is a very difficult chart to read. It's just a reminder of the carry framework, which suggests that people don't have to be fully abstinent and stable to get any take-home doses, that in fact, take-home doses can help people to stabilize. So typically 4 weeks on methadone. Again, typically we can use judgment around that, but if people can store and manage their doses, they're not using in high-risk ways, they're not exhibiting sort of really acute, risky mental health situations, there's absolutely a role for thinking about a Sunday carry or a couple of carries for work, and how you plan that between the patient and the pharmacy to be able to create that continuity. Note to the pharmacy that if someone misses doses or is coming in, perhaps they can contact you. All of these are really, really important.
Thanks so much, Dr. Wyman. This idea that I need to get stable, but yet I need methadone to help me get stable. So how do I get stability when I don't have the tools to get stable? And a lot of these recommendations really help to make changes there.
Hey, Andrew, do you want to start us on
Yeah,
case number 2?
absolutely. Yeah. So our second case, and I want to just quickly, we've had a lot of people that have put thoughts into the chat. We have somebody who said, reasonable to restart him at 75% of his previous dose, or at 60. We've had people say, I'd restart him on methadone at 50 and then add in some slow release oral morphine, 200 milligrams. So a lot of people seem to be already taking some more aggressive approaches, and I think that's great.
Yeah, and I would say I see Lisa's comment now. Yeah, I would not be expecting someone to come in every day for assessment before that pre-planned dose increase. I don't think that would work for the person or in my clinic. So if I were making the decision to do pre-planned dose increases, I would write them on the prescription. I would communicate with the pharmacy, but I would also put a note that if the person missed a dose, that to continue the prior dose so that the prescription doesn't get canceled because they miss one and then the pharmacy doesn't know what to do about that. And I also, in these kinds of situations where there are things that quote unquote, sort of deviate from old guidelines and what the pharmacy might be comfortable with, is I make sure that they know how to reach me. So they can reach me through locating, they've got a cell number that's not shared with the patient, but we need to be able to answer those questions when things look different than the standard prescription.
Excellent. Thanks, Dr. Wyman. Our second case, we're going to call him Tom, 35-year-old male, released from jail 2 weeks ago. He was on methadone, 40 milligrams while he was incarcerated, used opioids before incarceration, pills and fentanyl, but not in the last 3 months. Prescription was sent to the pharmacy for 5 days, but he couldn't get there beyond his first day. Therefore, the prescription was canceled. Bipolar, ADHD, alcohol use disorder, and cannabis use. Medications that Tom is on, quetiapine, trazodone, and gabapentin, does not have any fixed housing. So he reports drinking, some crack cocaine use, no crystal meth, no opioids. Urine drug screen shows positive for methadone, for hydromorphone, cocaine, benzodiazepine, and negative for fentanyl. So what thoughts? Feel free to put them in the chat, and curious to see what you guys would do.
Yeah. So, in this case, the sort of positive, right? He had a prescription for OAT. So someone, was thinking ahead, wanting to continue him on care at discharge. We know that that's such a high risk time for relapse and for overdose. But unfortunately, because of how things unfolded, which is probably not unusual at all, he didn't get to the pharmacy. His prescription got canceled. There may have been some ways to mitigate that with writing a longer prescription, asking that the prescription not be canceled for up to 7 days, for example. He's drinking quite a bit at this point, and although he said he's not using any opioids, his sample is still positive for hydromorphone and for methadone. Could his methadone be positive from almost 2 weeks ago? Probably not, although it's possible. So you might probe, and I would say it wouldn't be unusual for Tom to have been able to access a little bit of methadone or some hydromorphone tablets to keep himself going, because he was in pretty uncomfortable withdrawal from 40 milligrams, discontinued pretty abruptly. So this is someone we would consider to be moderate tolerance. He wasn't on a high dose of methadone, and also moderate risk of toxicity because he's drinking quite a bit and he's got some other medications on board. It could be an opportunity to offer buprenorphine, but he really adamantly does not want to go there. So this isn't someone that I would automatically start at 30 milligrams. This is someone where I would start at 20 milligrams. I probably would increase by 10 rather than 15. And I would be thinking hard about how we were going to be able to follow up, given his instability. Does he have a phone? Can he use someone else's phone? If he's still not sure where he's going to be and what pharmacy he'll be able to use, I would give him a printed prescription rather than faxing it somewhere that he actually can't get. I would write the prescription for up to 7 days. I was thinking about it as I wrote this. I might actually write it for longer. Like, why would we not consider writing it for 14 days? If this is a starting dose, so that if he runs into challenges, he gets there, he doesn't get there, that he can still begin the prescription. And in fact, maybe we don't need to cancel it if he misses 5 or more doses. It's a starting dose. Maybe we want him to be able to start it for any time in 7 to 14 days. So those are all things to think about. Again, when they're unusual, we need to document that on the prescription or speak to the pharmacist. And of course, think about the risks of overdose, counseling around overdose risks, naloxone kits. Andrew, I think there were a couple of things you wanted to add on to what we might want to consider in a case like Tom's.
Absolutely. I mean, being incarcerated and then getting out, I'm coming out, don't know where I'm going to live. Depending on how long I've been in there, I've been provided with medical care, although maybe not at the level that I would really hope to have. But I've come out now. I don't know where I'm going to live. I don't know what I'm going to do. I don't know where I'm going to get my meal. And I'm on methadone. And how do I continue this? Coming in and being offered some referrals possibly, or connection to available services. And there's a ton of housing services that are available for people. But how do I do that? And having somebody within the clinic, whether it's my prescriber or somebody who works at the clinic that can say, here, let me get you connected through to in Toronto, maybe through to Loft, and doing an access point referral, connecting someone to available places they can go to get food, and maybe taking some time to have like an initial conversation about hey Tom, do you understand that I'm going to write your prescription for 2 weeks, as opposed to just that, that horror story I told you where I was just handed a prescription and told to leave. Being able to provide some more person-centered care, because getting out of jail, you're already terrified in regards to what I'm going to do. More than just an naloxone kit is all I'm getting at.
Yeah, I really appreciate that. And again, thinking this is someone who is recognizing that he's at risk of relapsing, and he wants to protect himself. He doesn't want to go back to using fentanyl and expose himself to those risks. So would buprenorphine in either sublingual or injectable form be a great option? In theory, yes, but not if that's not what he's prepared to do. And so I think it's really important to meet someone where they are and think about what tools we have to offer them. Andrew, do you want to introduce us to
Absolutely.
Jasmine?
Jasmine's a 38-year-old female using approximately a gram of fentanyl a day, mostly smoking it, as well as crystal meth daily. On methadone and off methadone, unsure of what dose she was at, is not on any prescription medications, no other health conditions, or active substance use. Last dose, based on Connecting Ontario, last dose was 50 milligrams. That was a month ago. Hasn't ever been above 60 milligrams, or hasn't been above 60 milligrams in the last 6 months. She's been moving back and forth between her mother's and her boyfriend's place. She's not sure where she's going to be staying and what pharmacy she wants to use. She does not have consistent phone access and does not have ID. Urine drug screen is positive for fentanyl, benzodiazepine, cocaine, and crystal meth. So what would we do?
Yeah, we're going to zoom through a little bit, but I would consider, so we confirmed that on Connecting Ontario, her last dose was well over a month ago and never on high doses. Probably she had lots of challenges getting to the pharmacy to get her dose up for the reasons we can imagine. So she would meet our box for high opioid tolerance and no major risk factors for toxicity. So her initial methadone dose could be up to 40 milligrams. I would absolutely offer her the option of methadone plus Strom versus the higher dose methadone. We're not going to spend more time talking about that. This talk is about methadone. So let's assume that she chose methadone because she's been on it, she's familiar with it. And the challenge is going to be, how do we plan for a pharmacy? So we spent some time looking at where she's going to be, which is going to be the pharmacy, write this prescription for 7 days. Again, notes to the pharmacist that she can start it at any time during that duration. Please do not cancel it unless the patient misses 5 or more consecutive doses. For someone who doesn't have ID, usually it's helpful to call the pharmacy and let them know that the person doesn't have ID, but that they do have ODB coverage. We can write a description of the person so that that's already kind of pre-planned. And then given that she doesn't have a phone, how are we going to reach her when, we've given her, our phone number to call us for follow-up. So we got a mother's phone number and permission, again, not to share everything, but at least to be able to kind of pass some messages back and forth overall. So let's say that was a Thursday. Jasmine didn't get to the pharmacy on Thursday. She got there Friday and Saturday, pardon me. She missed Sunday. She comes in on Monday. She makes it. She hasn't had that dose yet. The dose is still feeling pretty low. She's only had 2 doses of 40. Curious about what's going on in the chat. I think I would probably continue 40 milligrams for another day and pre-write her dose to be increased to 55 milligrams the next day, and then plan a follow-up by phone on Thursday. She says no problem, she can call in so that she doesn't have to make a trip again, and she's going to have her dose increased before you see her again. So Thursday, no phone call, can't reach her. Friday, no phone call. As opposed to just saying, well, too bad, we don't know what happened to Jasmine. We try to reach her. We try to call her mother. We look at Connecting Ontario. We can see that she actually had her doses for 55 milligrams. And if we could connect with her, she'd be due for an increase, but we don't actually know how she's doing. So, this is a not unfamiliar dilemma, I would think. And, do you continue her prescription if you can't reach her? Would you adjust her dose up or down? What would you do? So in the interests of time, I'm going to say that we kept her dose the same at 55 milligrams because she probably needs an increase, but we just can't connect to really know how she's doing. So Monday, we get to speak to her. She's made it to the pharmacy Saturday. She missed Sunday. She hasn't been to the pharmacy yet. So you can see that she's had a dose on Thursday, but not Friday, Saturday, but missed Sunday. I know I'm going quickly, but I'll remind you about this approach to missed doses and titration that we put in our 2021 document, that we can consider dose increases for patients who repeatedly face challenges achieving those 3 consecutive doses. And what we're looking for is at least 4 doses in the last 5 days. We don't recommend increasing the dose directly after someone has missed a day. But if that day that you're seeing them, or the next day can be that 4th dose in 5, then we can pre-plan a dose increase. If we've spoken to them, we know that they are still at high risk of fentanyl use and they're experiencing little relief at their current doses and no sedation. So 55 milligrams for 2 more days with a planned dose increase to 70 milligrams so that we don't have to wait to meet again. All of these notations on the prescription. And Andrew, what would you want, us or someone to be saying to the patient? What do you think is important for her to hear?
It's important that she understands this. So, I mean, when I was on it, I wouldn't, if I don't know, if I haven't been able to get in touch with my doctor, I missed an appointment, go to the pharmacy or call the pharmacy to find out, is there still a prescription there for me? Don't just assume that there isn't one. That's really how it would come down, because I always thought, geez, if I've missed this dose, I've got to go back into the clinic, and it's currently Saturday. They're closed until Monday. I might as well just start using again, and not knowing. And I would say that always maybe having a clear understanding and having a conversation. And the best time to do that is maybe the first time that you sit down with your patient and say, hey, listen, we're going to do everything we can to try to help you. But some of this comes back to you as well. And so always be in touch, either walk into the pharmacy. Other options that might be available, like if you can't make it in for an appointment, give us a call. Maybe we can do a video call. Maybe we can do a phone conversation. That's what I would have wanted. So
I took down our last summary slide because I gave everyone sort of 3 seconds to read it. I'm sorry for speaking for so long. I don't know if there's just a few minutes for questions and answers. Jen, I'm assuming you've been kind of collecting those.
I certainly have. Thank you so much for a very interesting and thoughtful presentation. I think there's been lots of interest in these new guidelines. There are some questions around whether the guidelines will also address using SROM, sustained release oral morphine, particularly when in combination with methadone starts.
So the guidelines, yeah, the short answer is in using methadone plus SROM is still an option, as it was, and we'll talk about that. What we think is important is to engage in conversation, use the patient decision aid, and see what makes sense for the individual. We are still in the process of accumulating evidence about the benefit of long-term combined SROM and methadone. I certainly do that in some people, but I think it's important to be able to offer this as an option, recognizing that there are situations where SROM isn't going to be a great option for people. There may be renal disease, there may be allergies, they may be going into a treatment program where SROM is not an option. And I'm really curious to see how that goes forward, and certainly how our Ontario data, continues to look different than other provinces where this isn't a protocol.
Excellent. I think we are in the last few seconds. I would invite people to complete the evaluation. I put that in earlier. There's also been a couple of links added to the chat recently, and the next session will start at 11 o'clock for the panel. I think we're going to have to end with
Can I just say that if people have questions or want to continue this discussion, let's go to a chat room. We can call it methadone guidance, or message me or email me. I think, yeah, there's a lot to consider.
Excellent. I'll see if I can move some of the questions there. Thank you so
Amazing.
much, Jennifer and
Thanks,
Andrew.
everyone. Thanks.
Thank
Thanks
you.
for joining.